Hello, dear IFAB guests. My name is F Duška, and I am delighted to be invited to present a lecture on chloride, queen of the electrolytes or evil stepmother. That's the question we are going to answer today. Well, I have no conflict of interests relevant to this talk. And what I want to quickly go through is to have some physiological remark regarding the function of chloride in the body. We will then summarize clinical evidence of the effects of hyperchloridemia in health and disease. We will discuss some pitfalls in chloride measurements. And finally, I should answer the question which is in the title of my talk. Well, where does all this chloride come from? You know, there is now little doubt that life originated in the seas, and in the hydrothermal vents, the normal saline or chloride, which is the main component of the seawater and sea salt, comes from, and it's also a runoff or wash of the earth minerals by rainfalls. So this is where it comes from, and this is the childish questions why the sea water is salty. And obviously during the evolution, the unicellular organisms pretty much adopted the composition of the seawater, which then evolves. You can see it on cations in crab, but catfish, very similar then to vertebrates. But the chloride is pretty much constant component of the extracellular water of living species. Well, when we look at what is the physiological function that chloride plays in the human body, you can see vast amount of channels. So chloride, obviously the most important extracellular ion that is negatively charged, and there is a whole myriad of channels which regulate the movement of chloride through plasma membrane and also through organelles. So principally, they are most commonly divided according to how they are regulated. So voltage-gated channels, the most common family, ubiquitous, are this CLC chloride channel family. We know Bartter syndrome, which is in pediatrics a syndrome of metabolic alkalosis, hypokalemia and hypotension, which is genetically determined and which is caused by various mutations, like the mutation of the sodium, potassium, and 2-chloride in the loop of Henle. But type 3 is caused by missing one of this chloride channel. Apart from the others, the most commonly known is CFTR, the chloride channel behind the cystic fibrosis. From our intensive care practice, we know chloride channel from receptors like GABA-A receptors, which includes the benzodiazepine binding domain or propofol binding domain, glycine receptors, which are which bind, which cause inhibition in spinal neurons, and also some calcium activated chloride channel are in the inner ear and in the neurons regulating the peristalsis of the gut. Last but not least, some channel rhodopsin, which is responsible for vision. This is also chloride channel. So this is where we find chloride in human cellular physiology. But when you have somebody with high or low chloride, there are these symptoms derived from disorders of these cited channels? Probably not. So we derive most of the physiological chloride function from disturbances of acid base, renal physiology, and also some gastrointestinal symptoms. Why is that? Why is that? So let's have a look at acid base first. Imagine a patient with chloride levels of 120, okay? So normal levels between 96 to 106, let's say. Well, so this is hyperchloridemia, isn't it? So you would suppose this patient to be acidotic and hyperchloremic, don't you? Well, is it the case or is it not? Well, let's have a look. So imagine a patient in a normal acid base status with sodium 140 and chloride 105. So let's give him to start with a bag of normal saline, right? So you cause hyperchloridemia 120 and indeed acidosis minus 40. This is what we expected. But we can also imagine another patient which is having diabetes insipidus, a disease when you waste free water from the body. And it causes a concentration of both sodium and chloride in the same proportion. But this patient has alkalosis, so-called concentrational alkalosis. So chloride itself is not really what determines acid-base status, but it is the difference between sodium and chloride that has acid-base effect. Because as you see here, the difference between sodium and chloride in the case of patient who had received 1 liter of normal saline is 21, shrinking the space for bicarbonate and anions on weak acids, as you know from Stewart theory, whilst sodium chloride difference in the other patient is now 40. So normally it should be 34 or 35 millimoles, and if it's higher than 30 sodium, if sodium chloride difference is higher than 35 millimoles, this causes metabolic alkalosis. But if it's lower, this causes metabolic acidosis. So it is the sodium chloride difference, not chloride itself, that determines acid-base status. It has been realized by David Story back in 2004, and we also reproduced it in critically ill patients, that there is a very tight correlation between sodium chloride difference and strong ion difference. So sodium chloride difference is a very good representative of SID when looking at acid-base status. There is almost no systematic error in it. So obviously, we know from acid-base teaching that both abnormalities of sodium chloride difference are very well known. So if we have acidosis from too low sodium chloride difference, it could be caused by hypoosmolarity. Why is it in brackets? Well, it is in brackets because low osmolarity is much more dangerous for a patient in terms of brain swelling rather than acid-base disorders. Obviously, it can arise from infusion of any fluids with low SID, and also it can be a result of the tubular problems of sodium and chloride handling, like during the recovery phase of AKI. Alkalosis, we have seen an example of a concentrational alkalosis when we lose free water from the system, and thereby sodium and chloride are concentrated to the same extent, and hence the difference between them increases as well. Furosemide loop diuretics obviously washes out the hyperosmolarity of the kidney medulla and causes the loss of free water. And you know that any infusion solutions with very high SID, like bicarbonate or sodium citrate, would cause this type of alkalosis. This is not a difficult stuff. Let's look at the other effects beyond acid base. Yes, Well, of course, we cannot give chloride itself, and we can either give, in theory, HCl, hydrochloric acid, or we can give solutions that have higher chloride content than in human plasma. But indeed, there is always a cation which is being infused together with it. So to study effects of chloride itself, it's somehow challenging. But what was done was that in very old animal experiments by Wilcox, they demonstrated that infusion of hyperchloridemic solutions causes renal vasoconstriction, a drop or a decrease of glomerular filtration rate, and Dilep Lobo, together with Simon Allison in Nottingham, did a series of nice studies when they infused normal saline versus Hartmann or versus 5% glucose to healthy volunteers, and looked at their of the physiological behavior of these fluids in those healthy volunteers, and they discovered that compared to Hartmann's, the normal saline was retained for 56% of such a solution was retained in the body even after 6 hours, whilst Hartmann's, containing less sodium, caused more natriuresis, and the volunteers were able to get rid of this solution quicker. There is a large body of evidence showing that the postoperative hyperchloridemia is associated with more nausea and vomiting. Anesthetists know that. And we are aware of the study when sometimes people have a tendency to infuse normal saline to hyperkalemic patients in thinking that, well, if I give something that contains 0 potassium, is better for hyperkalemic patients rather than balanced solution with no potassium in it. Well, we know that it isn't true because the acidosis has higher hyperkalemic effects that are prevailing over some small concentration of potassium in balanced solution, and thereby the study was stopped for safety reason because of higher incidence of hyperkalemia in kidney transplant patients. So these are other effects. Well, is it significant clinically? This is another question, but relatively recent body of evidence in these all big trials, which I won't go into detail because IFAD doctors are familiar with those, and they all consistently demonstrated roughly 1% decrease in mortality. So this is something, 1 in 10 patients is saved, 1 in 100 lives is saved by chloride control politics. This is significant to me. How is chloride measured? This is the last point I wanted to discuss. This is not clear. And if you look at normal ranges at various hospitals, various laboratories, these are different. Why is that? So, most commonly measured chloride is in acid-base analyzer. And as any other electrolyte, this is measured by electrodes. And obviously, first of all, the chloride in the solution needs to penetrate close to the electrodes, which is immersed in a solution with known chloride concentration. And this penetration is facilitated by a molecule which is called ionophore. These ionophore, usually the structures are not published. It's an industrial secret of the acid-base analyzer manufacturers, but it is very relevant to what extent this ionophore is being selected, because if it is not selective, another anions like bicarbonate may cause falsely high chloride readings and therefore leads to inaccuracy. It has been measured, and if you look at chloride measured in the there is a difference between blood gas and central laboratory, and this difference was, it's sometimes quite significant, in order of 6 or 7 millimoles, and it's dependent on bicarbonate concentration. And long story short, now it is clear that modern blood gas analyzers are more precise, and they contain better and more selective electrodes. At least this study has demonstrated quite reasonable stability of a blood gas analyzer against central laboratory. Also, it should be stressed that in the central laboratory, they use dilution, and chloride, because it's of very relatively high concentration, is subjected to the same effect of dilution as sodium. So in case your patient's plasma contains high concentration of triglycerides or high concentration of proteins, because of the effects of dilution, chloride concentration as well as sodium concentration could be falsely low. This is not the case for acid-base analyzers, where chloride concentration is measured directly by ion selective electrode. So I can conclude from this that it is better to rely, when measuring chloride, to well-maintained and calibrated acid-base analyzer rather than sending it out. This is slightly counterintuitive because the laboratory is big and it's maintained by biochemists, so we tend to take it as a gold standard. For chloride and sodium, this is not the case. So, coming to conclusion, well, the question, chloride, is it a queen or is it Evol's stepmother? I don't think it's one or the other. It's neither, because at least in the infusion fluids, it can be easily replaced, usually by metabolizable anion, such as acetate, succinate, or lactate, and thereby we can give neutral solution which does not cause any disturbance of chloride in patient's plasma. When looking at acid base, we need to look at sodium chloride difference, not to chloride itself, because it is the sodium chloride difference that determines acid base status. We also learned that well-maintained blood gas analyzer is the golden standard of chloride measurement, and we know that chloride control has small but significant influence on mortality. It is now very well accepted that normal saline is a drug for the treatment of high strong ion difference alkalosis, rather than a normal maintenance solution. And with that, I thank you for your attention.